Hey guys, welcome back to my channel. Alright, so today we are at Kingston Public Hospital and we are going to an educational seminar called Vestibular Rehab. Right, so that's gonna be addressing issues with dizziness and balance. So I want you guys to stay tuned, keep watching, and I hope that you can learn something from this presentation. Also, if you haven't subscribed to this channel as yet, please hit that subscribe button. Share this video with your friends.
I would suggest that as a physiotherapist, you have to respect what they are saying and how they are describing. They might say that something is crawling in my head.
Eyes are doing all this bouncy, all over in one particular direction. In this case, you can see the eyes bouncing. And this is in a response to an imbalance in your system.
Everyone, my name is Anita Finley Parks. I am the supervisor for the outpatient physiotherapy department. I'm also the chairperson of our education committee. Today we'll be having our vestibular rehabilitation class, where on our agenda we have Dr. Diane Channer, who is our own ENT specialist that will be presenting on ENT pathologies. Also from overseas we have Dr. Pretty Jada, who will be presenting on physiotherapy management of vestibular cases. We hope that this session will be informative for you and beneficial to your practice. Do enjoy.
Good to be a part of you guys. Some of you I know. Some of you who will be anonymously my patients as well. And some of you I've yet to meet. COVID has forced us to a new paradigm where we do a lot of online meeting rather than face-to-face meeting. And even though I initially wanted to be there with you in person, since COVID we have been doing these lectures for my department online, and I have back-to-back meetings, so it'll be difficult for me to come down there since I can't go online for my next meeting from KPH due to the internet. So it's best for both parties, both meetings that I have, that I'm off-site today. But I want to divert your attention to the dizzy patient. Now, dizziness is one of the things that drives mortal fear into physicians and into healthcare workers generally, because it's one of those things that is always tricky to get a full handle on. It's tricky to diagnose. The patients can be one of the most challenging to deal with physically, challenging emotionally, because they're frustrated. Because the other part of it is that it's very difficult to treat as well. So I want to look at some of the more common types, and a little bit, not going too much into the deep core physiology of it, but just I like when persons have an understanding of what results in this dizziness. You know, if you can understand why you become dizzy, then in a sense it allows you to be able to empathize with your patients more a little bit, if you may. It also allows you to be able to understand what the patients are going through and how to try to figure out some of these things, because a lot of them can be figured out. A lot of them would be in your hands. So when we talk about a dizzy patient, I've for years been advocating that dizziness is considered the sixth sense, because if you think of the other senses help to allow you to interact with your world, interact with your work environment, and your sight, your smell, you interact with your work environment. But your sense of balance is one as well that helps you to interact with your work environment, because it tells you where you are compared to the world. And one of the first things you have to realize when you're talking about dizziness is that your brain can actually trick you. And you say, how can my brain trick me? Well, you're driving down the road or you're in a desert and you see a mirage. You swear that there's water up ahead, but there's none. There's so many other things that can give you a false sense of of what things are. And I'm going to show you how this interaction with your world and your interaction with the things around you can also have the same kind of effect. So dissipation, here we go. All right. If you just look at this wall and you say, oh, that looks like a nice wall, nice concrete wall from where I'm back home in the country. Everybody used to have some stone walls, and this looked like one of those typical stone walls. And you wonder, why am I showing this stone wall? I'm showing this stone wall just to reemphasize the fact that your assumption of what your world is may be different from what it actually is. You're looking at this stone wall. Is it really a stone wall? Maybe not just a stone wall anymore, because your mind and your eyes will tell you what something is based on its interaction, based on prior knowledge. But once you see it, you can't unsee it. Similarly, let's focus on this. Why am I showing the earth spinning around? Because right now you're watching this presentation and you're watching it, and you are sitting perfectly still watching it, and you're balanced. I mean, you think you're balanced, but are you perfectly still? The earth itself revolves completely on its axis in 24 hours. And the circumference of the earth is 24,000 miles. If you think of it that way, you'll realize that despite the fact that you think that you're perfectly still at this point in time, you are literally spinning even up to 1,000 miles an hour. But your brain somehow conceptualized this as ground zero, and therefore one of the first symptoms when an astronaut goes in outer space and outside of the realms of the Earth's gravitational pull and feel and turn, what happens? They don't have issues with their vision. They don't have issues with their hearing. They become dizzy because no longer are they spinning at 1,000 miles an hour. They are now spinning at a much slower rate, and the brain gets confused and they throw up. But what we're going to look at is a couple of outline, a couple of management skills, maybe get to the case reviews, but we can just discuss a few things generally. So one of the first things I like to tell persons or remind persons when I'm doing presentations like this, vertigo. You hear the name vertigo, but what is vertigo? Vertigo is a diagnosis. Vertigo is not a symptom. So when I hear patients come to me and say, what's wrong with you? I have vertigo. I say, no. And they probably think I'm just kidding. So they say, okay, I have the vertigo. I said, no, that's a symptom. If you went to a physician's office and you left the physician's office, and when you're leaving, you say, oh, doc, what's my diagnosis? And he says, belly pain. You probably pull down your glasses and look at him 2 times, doc, that's my diagnosis, belly pain. Why would you just look at him like that? Because in your mind, that's your symptom. So when somebody comes to you and they present to you with a symptom of vertigo, just like if somebody comes, somebody goes and they have belly pain, it's up to the healthcare worker to identify what is the cause. Vertigo is not a diagnosis, it's a symptom. The onus on the healthcare worker is to identify the cause, because only through identifying the cause can you direct treatment. Belly pain can be several things. A belly pain can be gas. It can be appendicitis. Imagine if you give somebody with appendicitis gas tablets. Imagine if you operate on somebody for gas. Now you see why a diagnosis is crucial and not just base your treatment on your symptom. So vertigo is not dizziness, not the same thing. Vertigo is that sensation. If you remember when you were a kid and you would spin and stop, and the world will still be spinning with you. That symptom that you have when you're a kid, where you spin and stop, and the whole world seems like it's still spinning around with you. That is the sensation of vertigo. It's really a hallucination. Why is it a hallucination? Because it's not actually happening. The world is not spinning around you. No. That's probably what Galileo and those guys thought when he thought that the sun spun around the earth. The world is not spinning around with you. you are feeling a sensation of rotary movement. That is what vertigo is. Dizziness is just something that we make up as human beings. We can put any amount of definition to it. Spatial disorientation, blah, blah, blah. Lightheadedness, you can have gas and say you're dizzy. You can have can have so many different things and you say you're dizzy. But in this particular case, it has nothing to do with vertigo directly. It's just a general terminology. Sometimes patients will want to think, if I say, all right, I say, when I tell them to explain to me what's happening to them, and I say, don't use the word dizzy. And I say, oh, imbalance. I say, no, I want you to describe for me. But we're coming to that. Disequilibrium, dizziness, many different words are used. Why is it such a throw off though? Because you could be fine and happy walking down, sunset walks on the beach, sunrise walks through the forest, whichever one you want to think about, somewhere nice and dandy. And then all of a sudden, despite your walking and you not having any problem, boom, the whole world starts spinning with you. And this is why it's so emotionally debilitating for the patient, because generally your hands and legs and everywhere else, the rest of your body can function. You just can't direct them in the direction that you want them to go. And that is the traumatic part. So what I like to think about it, and you guys will be able to appreciate this, I tend to think of the balance system as somewhat of a three-legged bar stool. And you'll see where I'm going with this. And all these legs are important for balance. You sit on the stool, you talk, you chat, you bend down, you tie your shoelace, you move over, you spin around, you lift up one leg, you do whatever. You're balanced because you're on the comfort of three legs on that stool. If something should happen and you should now be sitting on a two-legged bar stool, it's like you're on a bicycle. So you can do a lot of things. I've seen people texting whilst they ride, not sure how they accomplish that. But you can text, you can comb your hair, you can answer your phone, you can look across to your friend, but you realize that there are certain limitations just the same. You can't spin completely around and look behind you. If you're going around a sharp corner, you can't reach all the way over because you will fall. So even though balancing is still good, there is that restriction that you must recognize. And if now you're on a one-leg bar stool, balance is a constant nightmare. It's like you're on a tightrope. When you see those guys on the tightrope stretching out their hands, it's not because they believe they can fly. It's because you're trying to counteract and adjust their center of gravity. Because now, if a patient sees an object over this side and they want to reach over here, they will fall. They know that they probably have to shift their butt to the left to counterbalance and stretch their hand out to the right in order to ensure that they don't fall. So that is why when we think of the three-legged bar stool analogy, it makes easier sense to understand why it is we maintain balance. So there are three different legs now of this bar stool. One is the patient's eye. And you'll say, how does my eye interfere with my balance? How do I really get to this point where my eye is not going to interfere with my balance? Well, let me tell you a quick story. I teach by analogies, right? Even with my kids. So there was this circus, and persons went to this circus, and they would go down this dimly lit tunnel. And when they came out of the tunnel, invariably they would be like this. And then when they stepped out, they said, hang on, why am I like this? And they just straighten up themselves and go along. And they couldn't figure it out. And for years and years, people wondered why, when they walked down this tunnel, they would come out like this. And then one day somebody figured it out. When the tunnel was being built, the architect who designed the tunnel gradually adjusted the walls. Think about it. Where you're sitting now, your assumption is that your reference point for vertical is the wall beside you. You don't go up beside it and measure it with a spirit level or a plumb line to see if it's perfectly straight. Your assumption is that the wall is straight, and you adjust your body accordingly. Your assumption is that the ground is level, perfectly flat, and you adjust your body accordingly. And you say, well, nah, that would never happen to me. All right, let me give you an analogy that I'm sure happened to you. You pull up at a stoplight, a truck or a bus pulls up right beside you, completely blocking off your visual field on one side. You're all stationary. Then suddenly the bus moves off and you slam your brakes because you thought you were moving. Why did that happen? Your visual reference point for stationary became the bus. And so you adjusted your activity based on that visual reference point for being stationary. So your eyes play a huge role. And as I talk about the eye, I remember I had this patient who would just get dizzy at night. And she was wondering why. Why is it throughout the day I'm fine? Why is it that I would be fine throughout the day and I just get dizzy at night? And it so happened that in her case, she only, one of the legs of her stool, I'll tell you which one, the sensation, we're coming to that in a sec. She had lost sensation in her legs. And so her balancing throughout the day was mainly using her ear, balance organ in her ear, and her eyes. But at night, when the place gets dark, she becomes dizzy because she was focusing on her eyes so much, but she didn't realize it. Which takes me to the next point. Sensation. When you're walking around, your sensory input from your legs go up to your brain and tell you where you are in time and space. Remember I say it's interaction with your environment. When you are sitting down, sensation from your butt goes up to your brain. It's interaction with your environment. When you're doing all of these things, when you're walking around, you don't constantly check where your body is compared to your head. You don't constantly do that. So how do you know that? One of the greatest muscle groups that you utilize, the only muscle group that tells you where your head is compared to the rest of your body, your neck. Ask yourself the question, in your department, when somebody had a bad car accident and they suffered from whiplash and all the muscles of the neck are battered and painful, and so the sensation coming from them is just completely warped, don't they sometimes come in and speak about, oh boy, I'm dizzy, I'm so dizzy, and you wonder why are they so dizzy? Do they need a brain scan? No, the brain is fine. Why do they feel dizzy? Because they feel as if there's a disconnect between their head and their body. And that is why the neck muscles are so important when you're talking about balance. There are many patients who I've seen who come in dizzy because of neck spasms. And I'm tailoring this because I know in your department, you'll see a lot of these things. Patients come in so dizzy because they've been in an accident, something wrong with the neck, and they feel like, oh, I just feel like I'm going to faint. Why? Because your body feels as if it can't hold up your head. I want a better description. That's the second leg. The third leg now is one in which your ear and the balance organ in your ear, so-called your vestibular organs, and we're going to have a brief look at those. We've touched the other two. We'll have a brief look at those so you can see how this impacts on your balance. Now, all of these legs go up, and these legs now go up to part of the brain called the cerebellum, where everything is organized and put together and nice and dandy. And from there, it goes up to the top of the brain proper, where it's interpreted to give you this concept of balance. It's a construct of your brain based on your environmental interaction. That's how you maintain balance. But of course, a lot of these things can interact with different parts of your body. Your cardiovascular system, your neurological system, your endocrine system, your metabolic system. All of these things can interact. But overall, these are the three main input that goes to balance. And the ear interact with the sensation, and the sensation interact with the eye, and the eye interact with the ear, etc., etc. And that you have this complete dynamic that has to be perfect. No, maybe it's not perfect in humans, or it's perfect in humans, but we don't utilize it. If you think about a gazelle running from a lion, and that gazelle now running for his life has to make a sharp right turn. Now, if that lion wants a meal, otherwise he'll die of hunger, his vestibular system now has to say, okay, because he has to see the gazelle. The vestibular system has to turn his eyes, even though he's moving very fast. Yes, that's your balance system that keeps your eyes focused on a moving target despite you moving fast. He has to turn to look at the gazelle. He has to turn his eyes to look at the gazelle. That's the vestibular ocular reflex. Turn his neck to look at the gazelle, vestibular cervical reflex. Turn his legs by doing what? Sticking out his leg to one side, vestibular spinal reflex, to follow the gazelle. Otherwise, he'll die of hunger. Now, as we are more developed human beings, the extent of our balance system is to take up our phone and call Pizza Hut. Maybe if we lived in the wild, we would have appreciated our balance system more. Any gazelle, any rabbit that has a poor balance system will be the first to be eaten in the wild. But we don't practice that, right? Now, if we're to think of all of this, the history, therefore, is important. Examination, some of these things are important. But the history takes time. You have to ask your patients things. It's not good enough to just want a diagnosis. You have to ask your patient. You're an investigator. Right? Every detail matter, and even details before the detail matter. Somebody may come and say, boy, doc, boy, tell you what, I'm having a headache or I'm feeling dizzy. And you wonder why. All right, why are you feeling dizzy? Why did I start feeling dizzy Monday morning? And I say, okay, what were you doing Monday morning? Boy, I get up and I run to work early. Okay, so what didn't you do that you normally do? And the patient may say, well, I had to run to work early. I took my pressure tablets, but because I was rushing out, I didn't eat. And by the time I reached to work, I dizzy. Okay, chances are your dizziness is not necessarily because of your ear, because of your neck, or because of anywhere else. It's a good chance your dizziness is simply because your glucose level fell. You know, that's why the history is so important. Many patients who present for dizziness, when you really take the history, you may be surprised to find out what else is wrong with them. So the pre-event details, the event details, somebody may come in and say, boy, doc, I feel dizzy. I'm having a headache. I say, okay, so why you think you're having a headache? Boy, I'm not sure enough. Well, tell me why you think. Well, last week I was in a car accident and my head bashed up on the windshield. That can cause dizziness, yeah. So the pre-event and the post-event, what happens after the event, we have to take a little bit into it. Now, you may not necessarily have to dive in all of these questions, but just to give you an idea of the full extent of what are some of the kind of, or the types of vestibular issues that we may have. Is there a history of head and neck trauma? Did you have a bit of flu before all this? Were you having headaches? Any aura, like every time you're about to get dizzy, you see a flashing light. You know, these are the things that you may want to question when the patient comes in. Was it true vertigo? We mentioned what true vertigo was before. You know, that spinning sensation. How long did it last? Seconds, minutes, hours, days? What were the triggers? What were the relieving factors? Now, one of the most common one, which you'll know, is BPPV, which we'll come into in a sec. But it's the patient speaks about positional, and the classic thing is that, doc, when I get up in the morning, I feel when I get up in the morning, I feel so dizzy, and then I have to say, no. You see that getting up in the morning is a very complex activity, extremely complex activity. First, you have to tell me, let me tell you the various steps in getting up. I said, and the patients are surprised when I say this. So 1, you roll over in bed. 2, you move from a lying to a sitting position. 3, you move from a sitting to a standing position. 4, you're just standing there for a while. 5, you actually move off. 6, when you reach your destination, you feel dizzy. Which one of those? And the patients will sit down and think. I said, okay, let me think it through. Some may say it's when I'm rolling over in bed. Chances are that may be BPPV. When I'm moving from a lying to a sitting position, it may be BPPV. We're going to touch on BPPV in a sec. But when I move from a sitting to a standing position, that may be because of blood pressure issues. So a lot of those patients may be on blood pressure medication that drop their blood pressure too much, postural hypertension. A lot of those patients as well, when they walk off, may get dizzy because of a problem with sensing the ground, that they may have some numbness in their feet. Some of those patients, when they reach the bathroom, which is the first place most people go, that's when they get dizzy. And that can happen because in some cases, when you strain on the toilet, you get dizzy. You realize how complex it is. Instead of just a patient telling you, boy, when I get up in the morning, I get dizzy. And you write it down. No. They have to break it down for me, because there's so many steps in that process that if you miss the actual step, you'll be forever searching. And why the history is so important is that about 70 to 80% of most dizzy patients can be solved from the history, or at least have a very strong indication from the history. So that is why the history is so important. Now, as we're mentioning this whole ear thing, not going through this in depth, but the concept is this: if you're going to respond to your environment, you have to know when the environment changes. So if you're moving in a vertical direction, you have to be able to detect that. And that vertical direction is used with your saccule. If you're moving in a horizontal direction, you have to detect that. In your ear, the part is called a utricle. Don't worry about these terminology. But that will account for both up and horizontal movement. But here's another possibility. Let's say you're not moving up, you're not moving sideways, but you're right here and you're turning. That's where you hear we speak about your semicircular canals. And there are three independent planes to each other. That is why you have a lateral, but you don't have a medial. You have a superior, but you don't have an inferior. You have a posterior, but you don't have an anterior. They're in three independent planes, just like in high school math. I can't even remember most of this, but you talk about X, the Y, and the Z axis of three independent perpendicular planes to each other. But in our scenario, what is highlighted most in our scenario will be if you're on a ship or if you're in an aeroplane and you realize you're three independent planes. So moving your head from side to side like this is yaw, Y-A-W. Moving your head like this is pitch. And when I heard this, when I was in medical school and I heard this, I said, boy, it's always amazing how everything in patois can go back to something practical. When you hear patients talk about them pitch forward, yep, this movement is actually pitch. You pitch forward. So don't laugh at them and say, boy, use standard English. They are using scientific English. You can indeed pitch forward. And this is roll when your head moves like this direction. So there are three independent planes. Yaw is different from pitch, is different from roll. And if you're in an airplane or on a ship, then you'll have these different terminologies as well if you're a pilot or a seaboat captain. So where am I getting with this now? Now, this is pretty cool. This is what I'll see with my patients at the center. This is pretty cool. I'll let you. Right. What did I do? Okay. All right. Don't know why it's getting stuck on me. EBGBs. All right. Don't worry about it. But let's. I'll show you another one in a sec. But this was a picture of how a patient's eyes are fluttering, which you may see from time to time. Why does that happen? Let's say your balance organ on one side is pushing in this direction, and your balance organ on this side is pushing in this direction. No, they're pushing equally strong in opposite directions. So you don't seem as if you're moving because they're pushing equally strong in opposite directions. Now, what happens if this side becomes weak? If this side becomes weak, then this other side is going to push this side over. Now your brain is detecting that, and your brain is saying, but based on everything else that I'm detecting, I should not be dizzy. And this is throwing me off. Let me correct that. And when your brain corrects something, boom, it corrects it fast. So it slowly drifts over to this side, boom, it corrects it fast. Slowly drift, boom, it corrects it fast. Now remember that your balance organ is connected to your eyes. So what are you going to see in your eyes? This is what we classify. This is what we classically call nystagmus, where you see all these things in your eyes, and your eyes are doing all this bouncy, 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 all over in one particular direction. In this case, you can see the eyes bouncing. And this is in a response to an imbalance in your system. And your brain is trying to correct it. Now, one of the commonest causes of the true vertigo, we're finally getting to these things. I'll just give you some background stuff. We speak about benign positional paroxysmal vertigo, the classic BPPV, accounting for about 25% of patients I see at the center. And internationally, that's about the same thing. Probably 1 in 4 patients with true vertigo will have this. Acute labyrinthitis, vestibular neuritis, Meniere's disease, vestibular migraine. I'm going to touch on a little bit of some of these, right? Now, BPPV, if you think about it, in your balance organ, you have like a little straw. And on top of it, you have like a little stone. If you tilt your head to one side like this, it pulls and it tells your brain, okay, my head is tilted this direction. If you tilt your head to this way, it pulls and it says, okay, my head is tilted in this direction. But sometimes this little stone gets dislodged. And so when you turn your head to one direction, instead of just holding onto the straw, the stone keeps doing this. And so to you, your brain interprets it that you are spinning, 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 spinning. A classic case in point, you know, like if you have ice in a cup and you're mixing, and when you stop mixing, the ice still keeps going round and round and round and round until it settles down because of inertia. That is classically what happens when a patient has this kind of condition, BPPV. They still think that the room is going around even when they have stopped. Remember, your brain can trick you. And this is the classic example of when it does so. And what do you see with these patients? How do you test these patients? It's called a Dix-Hallpike test. It's a basic test. And most of the time, it's in one particular canal. So you have the patient lying down, turning your head 45 degrees to you as a clinician, extending the neck, and then you take them down quickly until their head hangs just over the edge of the examination table. And in that particular case, you're not just listening for them to say, oh, they're dizzy, because the diagnosis of BPV requires that you actually have some amount of nystagmus, which I'm going to show you in a sec. It requires that. And of course, you would have ensured that the patient's neck is fine. You don't want to go and be bending up a neck that's compromised, etc. You would have checked that from before. But this is what you may see. On the right here is Professor Haynes' picture when a patient goes back and the eyeballs are doing this. There's a slowness before it starts, so you kind of put the patient down and bring them back up immediately. It may take about 20-30 seconds to start, but after it gets rolling, you see the eyes doing that, twitching, 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 and that's classic benign paroxysmal positional vertigo. On this other side is a patient who I actually saw in the office, and that's what I saw with the eyes. She was trying to control it, but you could see the eyes bouncing, just bouncing, just bouncing. And those are the classic ways that you're going to see patients with benign paroxysmal positional vertigo, most times in the posterior, the back canal. Now, Epley's maneuver is a video. I'm not sure my other colleague was going to show some videos, so I'll probably skip this one because chances are that's what's going to happen. But the other classic one is called Meniere's disease. Now, if you think about it, Meniere's disease is a condition in which there's fluid in the inner part of your ear naturally. If that fluid becomes swollen for whatever reason, sometimes it's because of inflammation, sometimes it's because of other reasons. But if that fluid becomes swollen, the end result of that swelling is that the patient is going to feel like their ear is filling up. Like when you're going up and down a hill and your ear feels blocked, your ear filling up. And then after a while, pow, it's going to rupture. You're not going to hear the sound of the rupture, but what's going to happen is that because the fluid was feeding or responsible for the vestibular cochlear nerve, the balance nerve, and the hearing nerve. When that fluid ruptures, the end result is that you're going to have a condition where the patient is going to be dizzy. The nerves are not going to work anymore. So the patient is going to be dizzy, there's going to be hearing loss, and they may be ringing in the ear as a result of that hearing loss. So all this conglomerate of symptoms is what we tend to call Meniere's disease. I'm just going through the common reasons for somebody to have true peripheral vertigo. As we had mentioned, the backing up the fluid, and an important thing that leads to the backing up the fluid is simply salt. I'll touch on that in a sec, but simply salt. I'll look at a little bit of the treatment options for some of these. And if you want to help these patients, starting from simple things before even getting to any medication or anything, a salt-free diet. Now, in Jamaica, this is one of the most difficult things to achieve. When I mentioned this to a patient, they looked at me with, as we say in Jamaica, dry eyes, and I said, "Doc, you do realize even the national dish have salt in it. How am I going to stop eating salt?" To Jamaicans, oftentimes salt is just that little crystal thing. I remember salt-free, it's very salt sensitive. So I remember there's a patient who was coming to see me, and on the way she had 2 pieces of banana chips. I'm not talking 2 packs, you know. I mean 2 literal pieces. And after having those 2 pieces, boom, place starts spinning with her. And another patient who I had in a salt-free diet, and it was controlling her so well. And she called me one day and said, "Doc, I had an episode and I don't know what happened. I've been maintaining salt-free diet." I said, "Okay, what you had for breakfast? Let's go through." And she told me. I said, "All right, fine. What did you have for lunch?" She said, "Soup." I said, "Okay. Any salt in there?" She said, "No, Doc." I said, how did you flavor the soup?" 2 cock soup, Doc." I said, "Do realize cock soup have enough salt in there, right?" I'm not talking about excessive salt. I'm talking about the salt. So to the patients, they always say it's difficult. I had a patient who completely cut salt of her diet, out of every seasoning, rice, whatever, doing great. She had someone with her who would help her with the cooking. And one week that person got sick. And she had a new person who came that week. And she was very strict to the person, said, "Look, absolutely no salt in my food." And she said, "Yes, miss. Absolutely no salt." She said, "Yes, miss." That day she was supposed to cook fish. I said, "Boy, it's the first day on the job, you know, if I don't make this fish taste good, I won't be coming back." And of course, she said, "I'm not going to make it salt. Let's put a little toops, put a little salt on her finger, rub it in the fish." Person came home, and when that person came home and they took a little bite, boom, place started spinning. Permanent hearing loss, because the hearing loss had now reached the point of irreversibility. So it's not that simple. I've told patients, if you don't want to stop eating the salt, I'll put you on medication to help you to pee it out. And that's what I have them do sometimes. But besides that, there are other medications. I can give injections, steroids, gentamicin, a whole bunch of stuff that will help, or general surgery to reduce the impact of Meniere's disease. There are two others. One in which you can have an infection or an inflammation that goes to your balance nerve. Now, when that inflammation, it may have started from just a common cold, or it may have started from gastroenteritis, but eventually that infection gets to your vestibular nerve, and that nerve results, you end up with vertigo because it's affecting your vestibular nerve. If that infection goes to the ear of the ear, called the labyrinth, which not just is responsible for your vestibular apparatus, it's also responsible for your hearing apparatus. The patient can have both hearing loss as well as dizziness. Now, these are the common causes. So look at BPPV, Meniere's disease, vestibular neuritis or vestibular neuronitis, whichever way you want to call it, labyrinthitis, and I think the common one that we're going to look at now, probably the last one, which is not always spoken about, but migraines. Every time I mention this, persons look at me, whether they're medical students or not, they look up at me and say, Doc, what do you mean by migraines? Migraines are not just headaches. Migraines are blood vessel diseases. You know how you end up with a headache from a blood vessel disease? The blood vessel becomes a little leaky. And some of the fluid, some of the fluid that's in the blood vessel leaks out. And any nerve that it comes in contact with, it will irritate and the nerve won't function well. Most of the time, the closest nerve to a blood vessel is a pain fiber. And so when that blood vessel starts giving trouble, it's incredibly painful. Incredibly painful. That's why I speak about migraine headache. But where am I going with this? Let's say the blood vessel that becomes leaky is closest to your balance nerve. What do you think your presentation is going to be? You're going to be dizzy. So migraine can actually lead to dizziness. Migraine, if the blood vessel that's affected is close to your eye nerve, migraine can lead to blindness. If the blood vessel that's affected is close to the part of the brain that helps to move one half of your hand or your leg, migraine can lead to paralysis. I'm saying this because I'm sure there are at least 1 or 2 or 3 or 4 migraine sufferers out there. And what you have been doing is treating instead of controlling. Every time you get a headache, you treat it. But that doesn't prevent the problem, or that doesn't reduce the complications. All right, look at it this way. Suppose you have a relative who has hypertension and say, boy, they only take the pill when they have the headache. You're going to say you're crazy because the amount of damage that's going on in the meantime. Or if you have a diabetic person and they say, boy, they only take the insulin when they feel like they want to pass out, when their sugar get too high. You're going to say you're crazy. But how different are we when we just treat the migraine instead of controlling it? So vestibular migraine is real. And I use vestibular migraine because there's a time when this process started, when this diagnosis started, it was kind of known as migraine associated dizziness. But it's kind of difficult to tell your patient they are mad. So instead, now we just call it vestibular migraine. That's a little bit more palatable and easier to get away with. So these are the common peripheral vertigo things that you'll encounter in your day-to-day activity as practitioners. Now, there's some things that I'll just jump to that one. We mentioned, now you see why I mentioned the events that were there. If the patient has hearing loss, nausea and vomiting, if there are other neurological deficits, if somebody come to you because they're dizzy and along with the dizziness, they can't hold the urine, they can't hold the stool, red flag, you know? When does the post-event issues resolve? Do they completely resolve? Things like BPPV can completely resolve in a few seconds or minutes. Do they recur? In other words, what I'm trying to help you to determine is that you need to know the pattern. What is the pattern? Let's say this is a graph of the various types of dizziness. Is it that it happens like this, back down to baseline, back down to baseline, back down to baseline? Or is it that it happened like this? You have a spike here, and then it gradually over days taper down? Or is it that you would have a spike here, it goes down and it spikes back up, then it goes down, but it never really goes back down to baseline? What you need to learn is the pattern, because some things will clear up things for you and allow you to realize that there's something problematic going on. You need to ask the patient other things as well. What's in the history? What kind of medication they're on? They've ever had it? These are some things you need to get these details from the patient because they can clue you into something. Occupational history. Now, this is important. And I had a patient who was a pilot and came to me for dizziness and wanted me to clear him to fly. Now, I'm saying to myself, it's a good thing I ask him his occupation first. Because, I mean, if this person was an office attendant sitting down behind a desk, I could say, yeah, you could go back to work with limitations. But there's no way I can send a pilot back to fly who's dizzy. When you become dizzy in the air and the world is spinning around you and you don't have your reference point, how do you know where's up and where's down? How do you know where the plane is if there are no clouds in the sky and you can barely see the earth beneath you? Then what? I had a patient who was a diver, and he gave me something. I'm wrapping up now. He gave me a little tidbit as to how he survived an episode of vertigo underwater. And I said, how did you survive? And he said, Doc, as disturbed as I was, I remembered my training, and I had to stay perfectly still and follow the bubbles. I said, I never thought about that, but yeah, he said, yeah, that saved my life. The bubbles are always going up because he was there in the middle of the ocean. He can't tell where's up, where's down. There's no ground beneath him. There's no cloud in the sky for him to see. There's no tree looking over there so he can tell which direction is up or down. He is literally in the water having a vertigo episode. And he had to follow the bubbles. I just tell you that just in case there's somebody out there that it will help. Now, you're examining the patient, you're looking over your ENT exam, you're doing your Dix-Hallpike test, etc. I'm just wrapping up here. You're remembering the true peripheral vertigo diagnosis. Oftentimes, it may be one of these things that you need to comment on. BPPV is going to be probably the commonest one out there. The red flags that you're looking for, if the vertigo is there for a very long time, then you need to refer some of these patients. If the direction of the nystagmus is not side to side, or the typical one that looks like this for a BPPV, but it's like up and down like this and it's changing direction, yeah, then you need a physician to see them. If there's significant headache, if the patient is also having gait symptoms and hearing loss is getting worse, etc., yep, you need to have those patients be more evaluated. Now, in terms of the therapy, we're always going to speak about tablets, etc. I don't like any of these tablets. I think some of these tablets are from, well, I won't say that because I'm being recorded, but let's just put it this way. Some of these tablets are antipsychotic medications. So you have to ask yourself the question, what are you treating? Are you treating someone for dizziness? Or are you treating them for psychosis? As a matter of fact, the American Academy of ENT says that you shouldn't prescribe or shouldn't encourage any of these medications. You shouldn't encourage patients to get these tablets. You shouldn't, because it actually retards their eventual treatment. The therapy has to be individualized, and therefore the diagnosis, I stress this again, the diagnosis is completely essential. Vestibular rehabilitation is going to form a significant part of your armamentarium. And with that, I leave it right there. Thank you very much.
All right, thank you very much, Dr. Chanam. Very interesting presentation it is. And I'm sure my in-house audience and as well as the virtual audience will have questions that they'd want for you to provide clarity